I've been given the responsibility to defend something which is considered not so cool these days. However, something which is not so cool sometimes may be practical, and sometimes a lot of the research that we go through in today's times may reflect what's being done in biomechanical studies, what's better, but do they conclusively prove that our patients do better at the end of the day? So let's see. Number one, do you think she's having fun? I think she is. Do you think she's having fun? They both seem to be having fun. However, they're both having a great time. Same as India and maybe the West. We are a different population. So I think we need to, number one, think of our customs, our traditions, and the kind of people we are, the kind of patients, the economic status, various aspects. So we are a different population. So there can be a lot of debate. We can talk of techniques, we can talk of, sutures use, anchors use, this, that. But first, let's have a consensus on anatomy. So do we know where the supraspinatus attaches? We've been taught greater tuberosity, this, that, but where exactly? It's all different in different patients. So there's so much. And the size of the footprint varies from one study, which is almost double the size in another study, and this is what it shows. So we are not even certain about what anatomy is, let alone fixing it where you're supposed to fix it. What's important is technique, the way you do an operation. Same thing when it comes to instability surgery. We're doing a lot of remplaçages, but are they always indicated? I think the way you do a surgery is of paramount importance. You need to reduce the cuff anatomically, that is where you feel you should reduce it. You need to take bites at appropriate distances. You need to tie your knots such that there is contact between the cuff and the footprint. And the surface area may be better, but it's not a salvage for any kind of technical mistake that you make. So tears are different. As arthroscopic surgeons, we are more used to seeing this in India, because how many of us are only treating elite sportsmen? Most of these rotator cuff tears, I said 50%, are more often than not retracted and degenerated. And this is what you have. The quality of the cuff tissue and the bone itself, especially being middle-aged, older-aged women, are osteoporotic. So this is what you're trying to do when you're doing a double row repair. You are over-constraining a retracted tear. And you're trying to drill through cheese, let alone putting one little screw into it. If you're going to think about putting 4 and 6 screws into it, God save you. So bites through a degenerated cuff. I was talking to someone the other day, a cuff didn't look that degenerated. They took a bite through it, but it split from the musculotendinous junction. So a lot of things are not in our control. This is a classical image. If you want to buy a car like this, you better have a parking to park this car there. So we are a non-sporting population. Why are we trying to give them a Mercedes-Benz when their requirements are of just roti kapda makan at the end of the day? It's not so easy to do these operations also. Let alone doing arthroscopic surgery, shoulder surgery takes time to master. There's a learning curve. So not everyone can do a double row repair. So when you start with a single row repair, don't have a complex. I think literature and a lot of us are with you. So it's a technically demanding operation. So improve your skills. There may be definitive advantages of it, but first improve your skills. This is a Bugatti Veyron, and this is a Maruti 800. All right? At the end of the day, we are a population where cost matters. If we are going to reach the same destination at the end of the day, and that is what our current literature tends to show, I think I'm all right with a Maruti. It depends upon your perspective. So the cost effectiveness shows that it's a lot cheaper to do a single row repair than a double row repair. This is the most expensive house in India. It costs a bunch of money. I don't have such an expensive house, but I have a better view from my house. So I think what's important is there is no difference in patient reported outcome measures in any of the studies that have been done till today, vis-a-vis comparing single row and double row repairs. And this is a critical analysis by JBJS, and in which they say the clinical outcome studies to date in double and single row repair do not show any improvement in clinical outcomes at the end of the day. And this is a very recent review, meta-analysis on JSCS, which also shows that there's no difference in re-tear rates or anything else. So at the end of the day, I'd like to conclude my debate. At the end of the day, the king and the pawn go back into the same box. So if you've just got to get a good repair back with same outcomes, why should you be a king? Thank you.